Decision making is one of the most challenging aspects to caregiving. Especially as a parent, when you are fully responsible for the decisions that are made, or perhaps doing that in collaboration with the child. But there is a lot to consider, and we know that there are both internal factors related to decision making, ways that you might think about problems, the ways that you approach and gather information, gut feelings that you might have, but there's also external influences like the way that your child's clinicians convey information and engage in the decision-making process with you, opinions that people around you may have, information that you gather from other resources. And so I think that it's really helpful for all of us to hear how other parents have navigated both those internal influences and external influences as they've made difficult decisions for their child. And with that, I will hand it over to Gabi, who is our panelist moderator today. Welcome, Gabi.
Thank you so much, Chrissy, and to the whole team at CPN. I'm really, really thrilled to be here with you today. I am Gabi Conecker. I am mom to 12-year-old Elliot, who lives with SCN8A DEE. I am in Washington, D.C., and I'm also the executive director and co-founder of Deep Connections, who is partnering with CPN to hold this conversation today with all of you. I just want to start by saying I am so thrilled to see so many of you here and introducing yourselves. The fact that this is an audience of experienced caregivers, ethicists, social workers, psychologists, chaplains, hospice, palliative care. It just makes me so happy to see all of your faces and know that this is a conversation you want to engage in with all of us. So thank you for being here. Today's conversation is going to start with each of our panelists introducing themselves, telling themselves a little bit about where they are, where they live, and about their family. And then we're going to dig in deeper into how we have each navigated this decision making of interventions for our loved ones, and talking a little bit about how we do that decision making, how we lean on many of the professionals here on the call with us to do that, and how sometimes we have to kind of create our space to really be clear about where we are in our journey. So I am going to start by asking our panelists to introduce themselves, and I'm going to start with Lindsay.
Hey there, I am Lindsay Garrett. I am from South Georgia. My son's name is Hudson. He will be 6 in August. He has hypoxic ischemic encephalopathy, which is a very long term. That took me a very long time to realize how to say it properly. But it means that he has a brain injury, and it happened surrounding birth. And because of that, he has epilepsy, CP, among other things, and just is medically fragile. We do have a trach, we have a G-tube, and we've had to make a lot of decisions along the way. So we know a little bit. I'm a little nervous. This is my first time, but I'm thankful to be here. So thanks for asking.
Thanks so much, Lindsay, for being here with us. All right, Megan.
Hi, I'm Megan. I have 2 kids who are unique. Chloe is 15 and has a CN8A, and has a pretty complex medical history, including epilepsy and severe GI issues, and now has kidney and heart issues. And then my son is 17 and he is undiagnosed and has GI issues with chronic constipation, epilepsy, and autism. They both have autism. And we're just outside of Indianapolis.
Thanks so much, Megan, for being here with us today. Allie.
Hi, my name is Allie Schumacher. We're from St. Paul, Minnesota, and my son Colton is newly 4. He has a rare disease called CRELD1, which comes with a host of many different medical complexities, including epilepsy. He has a GJ tube, a port, immunocompromised, and we're actually tuning in from the PICU here at a specialty hospital. So medical decision making right at the forefront, even happening as I speak. So I'm happy to be here, a little bit nervous, but excited.
Thank you so much, Allie. We know how hard it is when you're inpatient and all the attention that draws on you. So thanks for being willing to be here with us to engage in this conversation as you are are in the mix of it right now. And last but certainly not least, Jennifer.
Hi, I'm Jennifer Seidman, and I actually am the Director of Community Engagement at Courageous Parents Network. But I'm here today really as the parent of three, and my middle son, Benjamin, was diagnosed in 1997 with Sanfilippo syndrome, which is a neurodegenerative disease. And he passed away in 2014. And I will add about medical decision making. I think in the beginning of his disorder, we were non-interventionists, so we didn't want to choose interventions, and that evolution changed over the course of his almost 18 years and how we approached those decisions. And now at Courageous Parents Network, I have the opportunity to interact with a lot of other parents to understand and learn more about what decision making actually takes when you're in the heat of it, and how it can evolve over the course of your child's life and a change in their baseline. So I'm happy to be here today and join the conversation.
Yeah, thank you so much, Jennifer. And it triggered something for me as you were talking a little bit about um, I wonder if this is the same for others, but that beginning of the medical journey, it's so scary to think about every new thing that comes. It's a new diagnosis, it's a new intervention, it's a new plan of care. And so I was the same in the beginning. I said, no, we don't want to do this. I think many people here can relate that the first intervention for a lot of us probably was the G tube. And that was like, no, I don't want to do that. I want my kid to eat. And it's tied to this very emotional, sense of how we care for and love and experiences we give our children. And then everything, every time it comes up again, it feels like another loss, another blow. So, framing that in from what I heard as I listened to all of you. But what I'd love to do next is jump in and have each of you share a little bit about your medical decision-making journey. Some of you have mentioned the kinds of interventions that you've come up against. So maybe sharing a little, maybe take a minute or two to talk about those different interventions um, and then we'll kind of dig in a little more about the process for each of those. So I'll start just by saying, my son has a G tube, then a GJ tube, and a vesicostomy, which most people don't know what that is, but that's to allow urine to flow out directly from the abdomen. So opening up um, there to release that urine more easily. So I'm gonna go ahead and ask Allie.
Sorry, trying to figure out how to unmute. My son Colton, he has before we didn't know he had a genetic condition before he was born. And so he was born early, a NICU baby for a month and sent home. And about a month after being home, we started the odyssey began, and it started with feeding issues. And so we started with like an NG tube, and I'm actually a speech pathologist and understanding the feeding part of it. And I remember that being, I couldn't fathom my child not eating by mouth. And it seems like it's such a small thing, but it's not, because our joys and our passions come from eating. And I remember that being actually the first really hard decision to make, was not trying feeding therapy, doing an NG tube. An NG tube turned to G tube turned to GJ tube. Now he's J tube feeds. We just stopped after a few months of TPN, after we had to completely stop feeding his gut. And so those were some really big, just stuff I couldn't even fathom as a speech therapist. Losing that pleasure of eating was really difficult for me, but it has evolved, and it turned into, I just want him safe and I want him to feel good. And that meant a J tube and skipping, the oral eating. And then the port, he is a super hard stick, and it turned into just being this super painful process for him over and over again with the hospitalizations, and deciding to get a port implanted in a not a usual typical way, for just IV access, which has now saved his life multiple times, especially with needing the TPN and things. And I reflect back to the decision to even have a port. I said, this seems too big of this is too big. This is too much. Let's try one more time to see if we can get an IV to work. And then it became a life-threatening thing. And so quickly you have to switch your brain and you have to change your mind and be okay with yourself and changing your mind. And um, what I've learned is that don't just take my initial feeling, have the feeling, give myself a little bit of time to process, ask the questions I need to ask, and then be okay if I change my mind on how that looks. And that's the same, not even for implanted devices, but medications as well, with, you know, lots and lots of seizure medications and things. So just understanding that it's actually like a grieving process to like get the device, have to grieve it, and then be okay with the next decision that I make.
Yeah, beautifully said. Lindsay, I see you shaking your head. What is that? Let's hear a little bit more about your journey.
Okay, I agree. I think I was so set on no trach ever. It was said in the NICU to us that Hudson possibly will need a trach. It was actually forced on us in the NICU. And we had a sweet nurse who said, I think he'll need it eventually, but I don't think he needs it right now. She said, get the G tube, let's go from there. The doctors were not listening to me, which was very hard as a new mom. First, this is, you know, obviously we don't want to be there. This is not the experience we thought we were going to have with our firstborn. And I think every time we came in, it was like doomsday almost. Like we were just excited to see Hudson, but it was constantly like, he needs a trach. He needs a trach. He's going to need a wheelchair. And I'm like, can we get to the stroller first before you start throwing a wheelchair at us? But yeah, we kind of fought the trach for a while until this past year. He got it in August of this past year of 2024. If you would have asked me a year before that if I thought I would ever do a trach, I would tell you absolutely not. But Hudson's body over time just showed us differently. And we had a not so nice experience with a PICU doctor forcing it. And then we had a great experience with a PICU doctor just kind of explaining what he thought it would do for Hudson. The mean doctor did not make up my mind, obviously, but the nice one taking the time to kind of explain how life-changing it could be, just really, it was very helpful. I don't think it's good to yell at parents and be like, you have to do the trach, because at the end of the day, they go home to their families who might not have these complexities, and most of the time they don't. And so I think it's hard for us as parents for them to just tell us one thing when we're the ones going home to care for our child with these new pieces of equipment and this new hole to take care of. And the G-tube was easy for me, I think, because I just wanted Hudson home. And I knew that was part of what had to get him home from the NICU, but the trach was not an easy decision. And I never thought I'd change my mind. So I think, back to what Allie was saying, like, you have to be okay with changing your mind. And like, there was like a little grieving process of like, I didn't want to do it. And now here I am saying like, maybe I will. And then even like the guilt of not doing it sooner once we did do it. So it's been a little bit of a process for us, but yeah, I agree with Allie 100%. You have to be okay with changing your mind, and you have to be okay with not changing your mind if you decide not to. So I think it's just beautiful that we're here today and being able to talk about this with other people that get it.
Mm. Yeah, and I think that's so important to mention the grief along this journey at every decision point, and that we change, and that's to be expected as our children change, we change as our interactions with the world around us and other families and other clinicians. It continues to evolve, and being open to that. So, and I'm loving seeing in the chat too, which is, we love hearing from you as we're going through here. So please continue to share your thoughts there, and we will have time at the end for some more discussion and questions. So drop those in the chat if you want to make sure you don't forget, because I know I always forget if I do not write it down. Jennifer, tell us about the journey that you all went on for interventions, from starting with no interventions to
Sure.
where it went.
I'll go back to something that Allie said, which was just that initial As moms, we all think about feeding our children as cornerstones of our parenting responsibility. And I can remember thinking, because when my son was diagnosed, he seemed like a typical child, even though he had been given a terminal diagnosis. And I was trying to envision my future and thinking to myself, well, someday I'm going to be the one that has to choose how, when, and when not to feed him. And that responsibility felt very burdensome. And I think it was what kicked me off to say, I'm never going to give my child a feeding tube. But the reality of our journey was I revisited that decision so many times. And we never ultimately gave Benjamin a feeding tube, but I want to share one story is my palliative care doctor said to me, my son was 14 or 15 at the time. She said, it seems like you're spending 2 hours to feed Benjamin every single time it's a meal, because he was still orally fed. And she said to me, can you, as your family, be spending those 2 hours doing something different that would create a better opportunity for Benjamin or a better opportunity for you? And I had to rethink that decision again, because she opened a space where I could look at it differently than just the physical nature of eating. And I see that in my work at Courageous Parents Network, where we have to think about those things. I would say that the biggest decision my family faced was my son, around about 14, developed a 78-degree curve of his spine, which was, of course, starting to impact his pulmonary, situation. And we had to decide whether or not we were going to fuse his spine. He had severe dystonia at the time. There were a lot of complexities, too many body systems sort of coming in. You couldn't just look at the spine. And I think that also complicates our medical decision making. Sometimes it's because we meet with a specialist and they're looking only at that one body system instead of looking at the complete child. And we needed to make a decision for his completeness. And that was a very hard decision to make. And ultimately, we chose not to fuse his spine, which probably ultimately, between that and no feeding tube, led to the pneumonia, which ultimately he had one pneumonia. He was doing really well. And suddenly we were faced with intubating, in which we had avoided that situation multiple times in our parenting decision making, remarkably, even though he had been under some anesthesias. And then unfortunately, it was the case that we were offered, do we want to leave him on a ventilator and see if the pneumonia would resolve itself, or would we choose to remove him from the ventilator because the pneumonia was so severe? So, the medical decision making really evolved. And I think, Lindsay, you brought it up really well, is to say, we have to give ourselves the freedom to understand our process of decision making can change as we live and learn, and as we live and learn and grow with our child, and they're changing. And paying attention to that is really hard.
Yeah. And I think it's coming to terms with it all too, right? Because we all start thinking we're going to have a very typical kid, and you think about all the things that you're going to experience and you want to give them. And the food was really important for me too, as a food person. I was like, that's what I want to cook with my kid. I want to have them experience all these flavors, right? So I think it's so important to think about that. And I love, Jennifer, how you brought up this holistic sense of our kids, right? Our kids are not one system at a time. And I see that, that happens a lot in clinical decision making, that it's like, well, we have to address this. Has to be done. Well, no, this is a whole human being. And I also just want to call out your pros and cons and loss and gain, right? That was really important too for me too, that decision making about the G tube. It's like, if you're spending so much time every day and they're spitting up their meds and you don't know how much they're getting, and then you're stressing and you're calling the doctor, and it's like, so it's just, what can you gain from this? I think that's such a powerful way to frame it for people too. Megan, I want to come to you. You've had a lot of medical interventions in your parenting journey. Tell us a little bit about that.
We have, and I have the unique perspective as well as how even between my two children, because they share something in common that's undiagnosed, and then Chloe has the SCN8A. As to how even between them, some interventions have been good for one and worked well, and we've had to proceed to more aggressive options with another. So Peyton is 17. He's my undiagnosed kiddo, and he suffered with chronic constipation and tried everything under the moon. Who knew poop could matter so much? And you would talk about poop so much. until you're a special needs parent, right? Like food and poop. So he at 6 years old had a mace, a Malone integrated colonic enema placed, and we would flush it every day for his chronic constipation, and that worked wonders for him. And then a couple years later, he got a G tube, and he intermittently uses his G tube. Even though he went about 5 years without needing it, every time he's had surgery, he's had infection. So we left it there because the risk of him needing it again versus the risk of infection having surgery, we're like, if it's not bothering him, let's just leave it in place. Chloe, on the other hand, she was diagnosed with the SCN8A about 3 years ago. Until then, we were working under undiagnosed. She's 15. We noticed around one that something wasn't right developmentally, chronic constipation, GI issues, and muscle tone issues. But her journey with procedures was around 4. We did the MACE because she suffered with horrible chronic constipation. At 5, we finally ended up doing a G tube. She teetered for years about possibly needing a G tube. With both kids, that's one of those that you're so scared of it, but then once you get it and you get the hang of it, you're like, oh my gosh, you don't have to wake your kid up to give them medicine. And then around 8, her GI issues, 7, 8, her GI issues got a lot worse. And we had to make the decision to do an ileostomy, which is a lot of body modification, right? Like we're modifying their bodies when we're doing all this. It ended up being a great procedure. It enabled her to eat more for a long time. But and then she's also switched to a GJ tube and is J fed. And we did really well like that for quite a while. And then recently we got the curveball. And as Jennifer was talking about the whole body, is we had everybody treating their system, and somehow kidneys slipped through. And now we have a major kidney problem. And she is now on TPN, which we thought we would never do. And we had avoided it for a decade. It's been on the table, if she can't digest her food, we're going to have to, put her on TPN. So we're really at this complex place where we're also having providers talk to us about interventions they think we should not consider, and talking with our palliative care team about what are we doing, why are we doing it, and how will it improve Chloe's life? Like, what quality of life will this give her or diminish for her?
Yeah, thanks for walking us through your double journey, Megan. A lot happening there. Um, yeah, I wonder if, it'd be interesting to hear how all of you navigated this decision making with your partner, if you have one at the time, with your family, with your community. How did that come into play? And I'll say personally that it took a lot of me finding my voice as an advocate personally to be able to have these conversations with my family about why we were making certain decisions and not feeling pressured, and being able to stand my ground there. And I wonder for each of you if that was part of your journey that you had to, work, maybe had to navigate with a partner who didn't want to move in one direction that you did, or with family members. So Lindsay, has that been your experience at all?
I feel like Blake and I were on the same page, but he was there before I was. It was one of those things where we switched Hudson's care just to get a fresh set of eyes, just to be sure we weren't missing something, that everything was on track. Because, like we were saying before, it is a whole child. It's a whole body. It's not just one thing. So before we moved forward with the trach, we actually switched care teams, got a whole new set of eyes. We both loved all of our new specialty doctors, and we felt like we were at a good spot. However, I do feel like we are very close with Hudson's grandparents, so my parents and Blake's parents, and they help us care for Hudson. We do not have nursing. Blake's mother helps me on Fridays, and my mom helps over the weekend. And so it was kind of one of those things where I felt like, would our parents still be able to help if we added a trach? We don't have nursing. We're in a small town in Georgia. Nursing is very scarce here. And then if you do find a nurse, it's hard to find a good one. And so we knew life as we knew it could really change. He was on board with the trach a little before I was. I think that's what's hard is I'm with Hudson 24/7. I'm up in the middle of the night with him. I'm the one suctioning it. Blake helps me a lot, but I feel like I'm the one taking him to his doctor's appointments and all that stuff. So he got there before I did. And then the guilt of afterwards seeing how life-changing it was and knowing I was what kind of held us up. But I think looking back though, Hudson wouldn't have been ready for the trach until we actually did it. But I was met with my parents and Blake's parents being like, whatever Hudson needs, we'll be there. It might be a learning curve for all of us. But we actually had really supportive parents. So I don't have anything to add there really.
No, it's great. It's a wonderful situation to be in where you have a really supportive network, which we'll take it, right? We need it from
Yeah.
anywhere we can get it. So yeah. Jennifer, in terms of your journey, did you have to navigate a lot of that with, parents, grandparents, partner?
I would say for the most part, my husband Stuart and I were on the same page, and we seemed to go mostly at the same pace. Although I really commend you, Lindsay, for recognizing that that isn't always the case within a single household. I also think what it brings up is, all of the factors that go into a decision, and I think oftentimes we're met in those medical situations where we're asked to think about it just in that little lens. But instead, what you're hearing from is maybe there's this teacher at school who's telling you something and encouraging you to make this choice because it would make the environment at school different. Or there's a nurse that's telling you one thing and you have to listen to them. And so I often got that situation in Ben's evolution where school was saying, if he had a feeding tube, he could stay here, or, we could do this, or we could do that, and it's hard to shut out the noise, I think, sometimes and see, um, to remember to think about what you think is best for your child and for your family. I think the biggest time, again, we'll go back to when we were choosing to fuse Ben's spine, and it was how to include my other two children because they were preteen and teenagers at the time, and there was a high likelihood that my son might not even survive the surgery. And it would certainly bring a lot of changes. It would have necessitated a feeding tube. It may have necessitated a trach because at that point we hadn't intubated him in a really long time. And with his condition, it's highly likely that children, their muscle system just breaks down, so that we were looking at, sort of an escalating. One decision was probably going to escalate a lot of other things in our life, and we were trying to figure out how to include them in the decision without burdening them with the decision, because they needed to feel part of it, but not responsible. And I think that's the hard part about decision making is it almost would be easier if it was just you sitting alone in your little tunnel. But it's not, because all of these influencing factors come in, and they make it really hard. And I will say, palliative care, and I just saw Pat O'Malley, my palliative care doctor, sign on. I will say that she helped me to screen out the noise or pay attention to the parts that I needed to listen to.
Yeah, that's powerful. And I think, something I just saw in the chat that came in too is part of that decision making is knowing, where your allies are and engaging with them and finding the people who you trust most and who will listen. So I think that's really powerful too. Anyone else want to weigh in on this point about community, Megan?
Sorry, my screen's being finicky, letting me unmute. Yes, I can weigh in on that because it's something we're currently dealing with Chloe's kidneys. We have family saying we'll get tested to be a kidney donor. But helping them understand that that process alone would diminish Chloe's quality of life, even if she were in the possibility of her surviving a transplant. That it's such an extreme measure that I know everyone means well saying, I'll get tested. I will, what can we do? But they don't see the risk that just the prep um, for a procedure like that is life threatening for her.
Oh, wait, no, you can't play inside.
There's, so it's, you definitely, people mean well and everything, but it's not always what's best for our child. And also it's hard on, I think, us as caregivers to have to explain our choices and the reasoning behind it when we're grieving and deciding and suffering those losses and knowing what some of our decisions mean as well in our own way, and having to explain that is also hard.
Yeah.
I wanted to just add that when I was making a lot of these decisions for Benjamin, it was sort of, pre-Facebook, and there weren't a lot of social media chats. And while I belonged to a patient organization, my access to them was limited to the times we were together for the most part until the end of his life. And those influences can be really hard because you're looking to the other families as an example and as a place of support. But sometimes, sometimes that feels great, and sometimes it can feel burdensome to the decision, because you're getting their influences. It's one of the things I love the most about CPN and the videos, because you can go in and listen to one parent, and if you don't jive with what their decision making or their feelings or responses are, you just turn that video off and pick a different parent. Try again. And patient communities sometimes don't always offer the grace of that, and
Yeah.
it can make decision making hard.
Yeah. And it's sometimes some of the part of the noise too, in terms of the groups, right? Not everybody is using up to date, scientifically sound information. So it also requires us to do our homework. But I think most of us rely pretty heavily on those around us who've been through it, who have navigated it, to help lead the way for us. And that's the beauty of things like Courageous Parents Network and Deep Connections, where it's like there are places people can go if they're undiagnosed, because we know that that's, or even if they are diagnosed, but they're not finding that conversation in their community. So I think that's a really incredible part of this as well. Megan, do you want to say something? I thought I saw you trying to unmute. If not, I'm gonna.
I can. I also have the perspective of we've had care providers not agree on what was best for Chloe. Like to have your teams of doctors kind of are like, one thinks you should do this, one think you shouldn't, and you're kind of caught in the middle trying to make the best decision for your child. And a lot of us also have rare children where, like Gabby was saying, there's not a lot known. And Jennifer was saying, so we kind of lean into that social media to find out what is the most up to date that's not out in publications that our doctors don't know yet. Like, how did the 20 kids that had this done respond to kind of help us make our decisions?
Yeah, no, I think that's a great transition for us to think a little bit more about how we navigate these decisions with our care teams, and where subspecialists come into the picture. And then, I mean, it sounds like all of us probably have had interactions with palliative care teams, hospice teams, that I know for my journey that has been incredibly powerful, because they tend to be more systems, right? Like cross systems, looking at things in a more holistic way. And the kinds of discussions that we have with them are also have a little bit more kind of opportunity to dig into some of the emotional, right? It's not just us, how do we manage medically? So I don't know if that's, I mean, Megan, maybe you can talk a little bit more about that since you started in terms of how you navigate these discussions with your teams and how you feel like you've had to stand and find your voice as an advocate for your children when they can't necessarily speak to the complexities at hand.
So I can speak to direct reference that we just had a few months ago. We noticed Chloe's baselines were changing. She went from walking, maybe not the greatest, but in talking, with her delays, but she was doing those things to not. And I remember speaking with palliative and our neurologists, and we ended up calling a care conference because I said, we owe it to Chloe to give her the best quality of life that we can. And if these baselines have changed due to progression of disease, okay, but we don't know without doing our work behind it and finding out if there was a cause for this. And we ended up being in the hospital for 9 days. Her mental state was in a point to where psychiatry had trialed medication for catatonia because she scored so high. And we did multiple EEG. Sorry, she's yelling in the background. Um, my mom's got her though. But turns out we found out she was in acidosis due to one of her seizure meds, so we had to hard stop. And we started a new seizure med, and within 48 hours, she was walking and talking again. So if we hadn't pushed for an admission to investigate further, um, with our palliative team calling the care conference, she would still be in that state. And because we did the care conference to try to force all of our providers to work together, we also found out Chloe's kidneys were in really bad shape. And she actually has really bad renal tubular wasting that had been flying under the radar. So that admission helped a lot. And unfortunately, sometimes we have to push and we have to nudge, and sometimes we have to put our foot down and, say, we're doing this. And I need everybody to talk and I need everybody to explain it to me. Then I need time to process that, and if we need to have another meeting, we're going to have another meeting.
Yeah, I think that's really, really important to not speaking to like, it's not feeling pressured to make decisions without more information. And I know, just because I know you well, that at the point when you were asked you had to change medications, it was going to be a question of, is this medication going to help her or is it going to totally destroy her? Could it kill her? Right? We don't, you're at
Yeah.
these decision-making points where it's,
Yes.
let's try this drug and it could be great or it could be catastrophic. And those are also
Yes.
decisions that we have to come
It
to the table
was.
making. Yeah.
Yeah, because with SCN8A, depending on if you're loss or gain of function, which Chloe kind of shows symptoms of both and is rare even within the rare community, it was, this medicine will either be very effective or she could go status. And I remember even calling Gabby and having conversations sitting in the hospital and, you know, weighing risk benefit and leaning on people, have walked paths and have the reach to put you in connect with people who may even know more, which I recently had to do again.
Yeah. Right.
So, and just because the team presents you with, like, Chloe just had neurosurgery and we went for a VNS consultation because her body's not tolerating medications well. Well, the neurosurgeon brought up deep brain surgery or RNS surgery, and that kind of blindsided us. And he's like, we can do it when we do the VNS. And I'm just like, I don't know enough about that. And it's okay to pump the brakes and take time. And we're just going to move forward with VNS. We're not going to move forward with DBS right now. If that's something we need to do, then we will, but it's not a need right now if we even choose to do it. That's a very invasive procedure. And like I said, it comes down to how will it benefit her and her quality of life.
Mm-hmm. Yeah. And I think one thing that this is triggering for me as well is remembering how critical it is for for clinicians to have some humility in some of these situations and say, I honestly don't know. Because I think a lot of us have encountered clinicians who say, this is the way we should do it. And Lindsay saying, no, you're going to have to get a trach. You got to do a trach. It's like, you may not know where the situation is heading, and being honest that this could happen, it may not happen. I think that's also incredibly important for caregivers to understand that. And when interventions are reversible, I saw a conversation in the chat about a G tube. That doesn't have to be for life, right? That is an intervention that you can pull back from. And like you said, Megan, it's sitting there for 5 years and we didn't use it, but it was there just in case. You could have taken it out and it could have healed over. And so I think that's something to just keep in mind as well. We're at about 15 minutes left, so I'd love to transition. Chrissy has been very carefully watching the chat, I know, and is gonna help us throw out some questions here from the audience about how we can help reveal some thinking on some of these other topics or questions that you all have. So
There's one question, Gabby, that's come up in different forms, but is essentially getting to, because we have a lot of clinicians on this call today who want to know how to be helpful. What has a clinician or provider done that's been helpful in your decision-making process? So this could be something they said, a question they asked to get you thinking, like Jennifer mentioned earlier, something they did, like just holding space, and what that meant for you or what that looked like. So if each of you could just share maybe one anecdote of something that was really helpful, that would be great to hear.
Mhm. And people are weighing in on the chat as well, which is fantastic. Keep the conversation going there as well. I think, Jennifer, the one you shared earlier about, could this make quality of life better? Is there something else you could be doing with your time that you're spending here? That was a really powerful one for me and for you, it sounds like too. But anything else stand out for you?
I mean, I think the one very helpful thing that happened in my son's life was actually getting all of the components, all of the specialists that he was seeing in one room to talk about his spinal fusion surgery, and just to have each of them explain to us, how it would impact that body system, and then have them also alternately think about how the other body systems might influence that decision as well. So, we couldn't control his dystonia, which was always pulling him to one side, which was complicating his curve. So how was the neurologist who was in charge of his dystonia thinking about that with relationship to the spinal surgeon who was really just wanting to put a rod in and straighten it up a little bit, And I think getting to a point where there's a physician who will advocate for a situation like that and really ask and challenge the other clinicians to think about it, because sometimes a care team meeting is just a lot of people talking, but they're not really communicating. And so I think and the burden of that often falls on the parent to turn around and challenge the different physicians to say, hey, wait a minute, stop and think about what this person just said. And so that, I mean, again, I think that's how palliative care was so helpful to me, because they acted as that interpreter.
Jennifer, I agree with you on that. And also with palliative care on our side, you can also use them as the facilitator so that you're not constantly having to relay the information from each specialist to each other. Like you're the telephone, you are the email, you're constantly relaying that, and they can be instrumental in also pumping the information between the specialists as well to help them keep up to date on each system.
Yeah, and Lindsay, you're welcome to chime in here too. One thing that I think came up in the chat was about, do you connect families with other people who have been through these procedures, so that they can hear directly from others? And I think that's an incredibly powerful thing to do. If you have families that are willing to speak with others who are facing that decision, I think that's been one of the most powerful things for me, is being able to speak to others who have been through it. For example, with G-tube, most families that I talk to about G-tubes, they say, I wish we had done it sooner. I wish I didn't delay so long, because it's such a challenging and emotional decision. But hearing that every other parent that I talked to said, I don't know why I waited so long. I wish I hadn't waited so long. That is a message that you as a clinician, it's harder for you to, put that in their ear, but for hearing from other families and about what could potentially go wrong, right? Like what else could happen? What do I need to be on the lookout for? And I think as clinicians, that's something that you can also do. And Jennifer has talked about this as well, right? Like in that multi, care team discussion, it could have, this could happen, this could happen, this is what you want to be on the lookout for, this is what the care involves, right? So that from your point of view, as a clinician, you can help prepare the family to understand what that intervention means in terms of, the ongoing care and challenges or benefits that might come from it. But other families can speak really, really much more to that. And I think, being really honest and open about that is really important. Lindsay, did you want anything to that?
I think that, yeah, that's when we first came home from the NICU, when you first have a child and, you weren't expecting this medical life that you've been thrown into. I had to kind of change the social media game. Like I had to unfollow friends from high school that we were pregnant at the same time because they were having these beautiful, like golden hour experiences, and that wasn't our story. But through that, I started sharing online, and that has been the most healing for me, but also has been the most helpful for me because I have gotten to talk to other families that have been through things before me. And that has been very helpful. Now, what has been best for their child might not be best for my child. So I always have to think back to like who Hudson is, what our goals are for Hudson. But it is beautiful to talk to other parents and know that like I can do this. If we get a trach, I can do this. I've seen other families do it. It's not the end of the world. And I think that's just beautiful about social media and groups like this is we can talk to other people that have been through similar situations and have had to make decisions like this.
Right. Christy, what else do we want to jump into here?
There's a question about the decision to find a new care team versus continuing to try to come to decisions with different opinions on a team.
I would love to chime in on this. I wanted to in the thing, but it was going to be too long. For us personally, because we did change care when Hudson was like 3-ish. We loved our care team. We were with Children's Healthcare of Atlanta. We loved them. They were great. But Hudson went through a very scary illness where we almost lost him. And that illness scarred his lungs and kind of like shaped a new Hudson. He had a new baseline. He was not the kid that Choa had been treating for 3 years. And we had to go to a local children's hospital that was closer during this time. So they didn't see him during this illness. They didn't really realize how much this illness affected him. So after we came home, when we started seeing our specialist, it felt like they were still hopeful that the old Hudson would come back. And we knew in our hearts that wasn't happening, that we had to like treat him now, like who he was now. So that's what made our decision when we keep going to our specialist, and they did listen, but it was almost like, let's give it more time. Let's give it more time. But then we're at home treating this new baseline and it feels like we're not getting support. And so that's what let us know personally that it was time to make the switch. I think when you feel like your needs aren't being met anymore, that it's just time to switch.
Yeah, and I think if you're feeling like you're not getting the information you need, the support you need, because a care team shouldn't just be thinking about the medical interventions, thinking about the family, what we're going through, checking in with us, asking how we're doing, where we need support, and thinking about connecting us. It was a long time before I even knew that there was such a thing as a hospitalist, right? And years into our care, somebody's like, "Oh, you'd probably be a really good candidate for this team." And hospitalists changed our lives, and palliative care because they brought a different kind of perspective to the conversation. So I think as clinicians, finding the right resources to connect us to, I see the Child Life is in the chat too, like where can those specialists come in and help? Where can social workers come in and help? And to recognize that growing our care team and people who can help support us is going to really give us more opportunities to process, and connecting to other families, and whether that is through your institution, if you have families who are willing to speak out, if you sending people to Deep Connections or, Courageous Parents Network. I mean, that's what we're here for, is to support these families. We have great resources um, on our websites, but also we have a whole, catalog of names and families who are here to support other families. So thinking about the resources in the community is really a powerful thing too. All right, Christy, you want to keep us moving?
Yeah, I'll try to do one, two more questions. So, as you mentioned, someone from Child Life made a comment in the chat, and there have been a few comments from psychosocial providers, so Child Life, social work, psychologists. And so, one question has been, how have any of those providers been helpful, generally or as part of palliative care teams?
So I guess I can weigh in. Our palliative care team does have social work on board, and they also look at the needs of our family and what support we may need. And they offer to make referrals for my husband and I, and also our son, if we want therapy. I mean, Lord knows we all need therapy, but do we want therapy right now? um, and also, asking how we feel about the process, and if there's things that we need or that our son needs. Like, we got him into therapy because with him also being complex, and with Chloe's medical, making sure that he has the support he needs, because he is starting to understand how serious her conditions are as well. So I think those aspects really help look at how the child illness and complexities affect the whole family, not just the patient, but the entire family.
Yeah. I also want to address something that came up in the chat about how do you get your team to see your needs in the new baseline when your child is having declines, but it's not happening during hospitalizations. And I'm curious, I mean, you all have been through this. You're home with your kid. Megan, they're not walking, they're not talking. There's declines, but you're trying to communicate that with your team. You don't have staff to help you. Like Lindsay said, nursing is scant, no matter where you live in this country, either there's no options or not very good options. So, how do you communicate that with your care team to make sure that they're understanding that you have concerns that you want to be addressed? And I'll start by
I
saying,
think for
from,
me, when
oh,
we got,
good. Yeah, please. I didn't hear
sorry,
you
sorry.
come in. No, please,
I
yeah.
think Okay, I think for me, it was just being honest with our providers. I think when I finally was just like, this is what's going on, this is how I'm struggling with it. I can't help him anymore. I need more. I need support. I need to know like what we can do at home to help him. Like, we are struggling. We are all we have. We don't have nursing. And I think being open and honest with them about our struggle, that's hard for me. It's hard for me to go in and be like, look, I'm struggling caring for my own child. But I think that's when they really started listening and being like, oh, like they are struggling. We need to help them. And then that's when tests were ordered, and that's when more was moving. So I think just being honest with your provider and your palliative team about how you're doing, even if they're not asking, just being like, here it is, here's word vomit, but I need help.
Yeah. And I'll say also, I think if they're not listening, maybe that's a good time to think about getting a care team who will be more responsive. And, I know for me, honestly, getting into the hospital for appointments is very challenging. All the equipment, it's not easy to get in for an appointment, but sometimes I drag ourselves there with all of our stuff and say, look, I need you to look and listen. This is what we're experiencing. This is not our baseline. We need help. And we want you to do this kind of a test. Can you check for this? This is what I'm thinking. I want to brainstorm with you all. And hopefully you don't have to drag your child to, the hospital. I hate going to the hospital because that's where people go that are sick. I don't want my kid to get more sick, right? So, having an honest conversation with your providers and saying, I'm very concerned if it doesn't feel like you can help me right now, I'd love to talk, with somebody else who might be able to listen, and maybe they won't help you, or so maybe you go ahead and you call and you say, I need to find somebody else. And that can be hard to do, especially if you're in a rural area or there aren't a lot of options. But, reaching out to your local community to say, is there somebody else that have you guys been able to reach somebody who's able to do to support you? And I welcome that mom who put that in the chat to reach out to me if she wants to talk more. And, because this is not easy to navigate alone if you don't feel like you have a community to talk about that with. I put my email in the chat for anybody who wants to follow up with me. And I know there's a lot of people on here who are part of our community. We're almost at time, so I just want to quickly thank all of these panelists who took time out of their busy caregiving schedules and are here to share their experiences. It's been really powerful for me. And it always is. And I think that's something to remember, that listening is so incredibly powerful when you can listen to the caregivers. That's a key point, right? And make sure that you're taking in what their greatest concerns are. That may not always be your greatest concerns, but as caregivers, we know our kids best. We are really seeking quality of life. And as you can listen to these families here today and with all of your patients and as caregivers who are on with us as well, that's the most critical part, is listen to where we are on our journey and help support us to get the resources and support we need to make the best decisions possible. So I'm going to hand it back over to Chrissy to close us out.
Yes, thank you. So well said. We want to thank all of you for joining, our panelists, and Gabby for moderating this wonderful session today.